Welcome, everyone, to the August 7th session of the Rare Bone Disease TeleECHO Clinic Series, the beginning of our 7th year of this series. My name is Melissa Bernardi. I am the Chief Development Officer for the OI Foundation, as well as the Director of the Rare Bone Disease Alliance, and we're just so happy to have you all join us today. We have a big schedule today, so without further ado, I'd like to pass it on to Dr. Laura Tosi, our chair.
Welcome back, everyone. I cannot believe it, but this is the beginning of year 7. It's been such great fun to do. We have a lot of busy work. So before I introduce our speaker, let me get that out. Next slide, please. So please give Melissa a break. No matter who you are, don't worry, we'll love you, but please sign in so she doesn't have to figure that out at the end of the day. And of course, if you want your free CME, don't forget to do the red cap evaluation as well. Next slide. So our closest sessions, please note in September we'll be a week late because of ASBMR. So Sandy Sandhouse will be talking to us about the pulmonary aspects of OI, which have become so important to recognize. And then on October 2nd, so then back to the first Thursday, Chris Novaks will be speaking about maternal mineral and bone metabolism during pregnancy, lactation, and post-weaning. Next slide. Then the OI TeleECHO is going to take a breather after December. So be sure you catch their final presentations. And we'll have Kathy Raggio speaking about cardiovascular health next week, August 13th. And then my colleague, Natasha Shore, will be speaking on the clinical and genetic evaluation of non-accidental trauma versus OI in October. And again, something that I'm certainly called on, and I'm sure glad to have her support more often than I like. Now, hope I'll see many of you at ASBMR. Several things we want to call your attention to. Remember, we're doing a pre-meeting whole day event, which is going to be, I think, quite tremendous, on rare bone disease from the genome to the lived experience. Then Friday, don't forget the pediatric and mineral working group dinner, future therapies in children with calcium dyshomeostasis. And that you can register for with your regular ASBMR registration. But please get your cameras out or your phones out. We really hope you'll join us at the early and mid-career investigator reception on Friday evening. And you do need to register for the complimentary admission today to help us out with our planning, and the QR code is there for you to the right, and we'll try to find other ways if you need it, but there it is. And then last but not least, as you know, we're working on developing a Washington, D.C. metabolic and rare bone disease club, but Zoom has told us the world is our oyster. So we invite you to attend if you're available. On Thursday, the 11th, so busy day on September 11th, we have the rheumatology and nephrology complications of XLH. And we don't have a full plan yet for November, but we'll be focusing on achondroplasia. So those are coming up if you want to put them on your calendar as well. And so, then let's get back to the matter at hand. It is a great pleasure to welcome back Dr. Mortier, who's going to be speaking to us on Stickler syndrome, clinical phenotype, and its genetic causes. In my clinic, this is one of the most variable syndromes, next to OI, that I see. So I'm eager to be brought up to date. We welcome you back. Thank you so very much for being with us.
Okay, thank you very much, Dr. Tosi. Do you see my slide?
We sure do.
Great.
Okay, that's good. So thank you for the introduction and thank everyone for attending this lecture. And also congratulations to the society and the organization committee for their 7th year. So the topic today is Stickler syndrome. I want to give you an update on Stickler syndrome, tell you something about the clinical phenotype and its genetic causes. I have no particular conflicts to disclosure related to this topic. So Stickler syndrome was initially described for the first time by Dr. Stickler, Gunnar Stickler, who was a pediatrician at the Mayo Clinic in Rochester. And he reported on the first family in 1965, a family with a multi-generation involvement, combination of ocular abnormalities such as progressive myopia and retinal detachments and arthropathy. And so he described this as hereditary progressive arthro-ophthalmopathy of ophthalmology. No, ophthalmopathy, sorry, there's a mistake there in my title. And subsequently, other families were reported, and these other families also did involve hearing impairments. And then after a few reports, the condition was then called after the original reporter. So it was called as or considered as Stickler syndrome. So in general, what is Stickler syndrome? It's hereditary connective tissue disorder. It usually has autosomal dominant inheritance, and it involves different genes, different collagen genes. So it has locus heterogeneity. And essentially, it actually involves 4 organ systems. First of all, the eye. And then you can read the most prominent features, which are congenital severe myopia, spontaneous retinal detachments. These are the most important ones, but also chorioretinal degeneration, presenile cataracts, vitreous degeneration, and open angle glaucoma. And then you have the skeletal system, essentially characterized by early onset osteoarthrosis, already starting in childhood with joint pain. There is also some joint hypermobility, but this is rather mild in my experience. And on radiographs, you can see spondyloepiphyseal changes, such as flattening of the vertebral bodies, a bit of irregularities of the vertebral end plates, and epiphyseal changes mainly affecting the lower limbs, so the hips and the knees. But this is rather mild in comparison with, for example, spondyloepiphyseal dysplasia. And then we have the orofacial system, so cleft palate, and if it's in combination with severe micrognathia, we know this as Pierre-Robin sequence. But the clefting can be mild, like bifid uvula or submucous cleft. And then you have the flat face, the mid-face hypoplasia, and lower nasal bridge, which are facial features of the affected individuals. And then finally, we have the hearing system, where you can have sensory neural hearing loss or conductive hearing loss, or a combination. Now, if we look at the locus heterogeneity in Stickler syndrome, we see that several genes are listed there in this table. And the most common gene involved is the type 2 collagen gene. So COL2A1 is in about 80% of the cases the causal gene, followed by COL11A1 in 20%. And then we have rarer forms, COL11A2, and then the different collagen 9 genes that are responsible for the production of type 9 collagen. As you can see the mode of inheritance. So the most prominent ones and the most frequent ones have a dominant inheritance, whereas, for example, the collagen 9 genes have a recessive inheritance. and then the proportion of pathogenic variants detectable by method is maybe not so important. Now, if you look into the literature, and certainly in the recent literature, you will find some reports claiming that mutations in other genes like BMP4 and the other ones that are listed on the slide can have also a condition that has some overlap with Stickler syndrome, but I will not go into detail in these genes because, in my opinion, they are really not causing what I would say classic Stickler syndrome. So I will not touch on that, but we can certainly discuss those genes if we have some time left and if this is an interest of you. So we are talking about collagen genes, and here you see a cartoon of the cartilage matrix with the chondrocyte and the extracellular matrix, and type 2 collagen is the major fibrillar collagen together with type 11 collagen. And on top of that, in red, you see type 9 collagen. So type 2 and type 11 collagen are the fibrillar collagens. Collagen type 9 is not really a fibrillar collagen, it's more a fibril associated collagen. It belongs to the facet family of collagens, and facet stands for fibril associated collagen with interrupted helical domains. So remember, collagen type 2 is the major one. Collagen 11 is related to collagen type 2. I will show you in the next slide. And then on top of the type 2 collagen fibril resides type 9 collagen. And here you see this a bit more in detail. So you see the major type 2 collagen fiber with type 11 collagen inside and also around of it. And the function of type 11 collagen is believed to play a role in the fibrinogenesis of type 2 collagen, and also it determines the lateral growth of the fibril. So it controls a bit the size of the type 2 collagen fibril. And then again, on top of that, in red, you see type 9 collagen. So these are the collagens that are involved, that are important in the pathogenesis of Stickler syndrome. I don't want to go too much into detail about the biosynthesis of the fibril collagens, which are in this respect type 2 and type 11, but there are a few things that you need to remember. But first of all, you need to know that these collagens are first produced as individual procollagen chains, and then they will form, in case of type 2 and type 11, they will form trimers. And this formation starts at the carboxy terminal end. So it's important to remember that, because that means that if you produce a truncated protein lacking the carboxy terminal end, that protein will not be able to associate with the other collagen chains. So it starts with chain association between these individual procollagen chains at the carboxy terminal end. And then the major part of the protein will form a triple helix configuration starting at the carboxy terminal end towards the amino terminal. And then the molecule, which is a trimer, which is in type 2 collagen, in case of type 2 collagen, a homotrimer, will be produced in the extracellular matrix. And there you have enzymes, specific enzymes like the amino and carboxy propeptides, or enzymes that will be responsible for cleavage of the amino and carboxy propeptides. So the non-helical domains are cleaved off, and then these individual molecules will assemble and cross-link to fibrils. So remember the importance of the carboxy terminal end for chain association and triple helical formation. The other thing that you have to know is that in order to make the triple helix possible, you should have glycine at every third position in the triple helical domain at least. And so glycine is very important. It's, as you know, the smallest amino acid, and it allows the three chains to form a triple helix, because it's small and it's also residing at the internal side of the triple helix. So you can already suspect that glycine substitutions will be pathogenic and will cause collagen disorders. So you have, as I have shown you in the table before, so you have different forms of Stickler syndrome, and I will start with the most common one, which is the COL2A1 related one, also known as type 1 Stickler syndrome. Remember, it's the most common form. About 80% of the individuals with Stickler syndrome have this type 1 Stickler syndrome form. It shows autosomal dominant inheritance, and it's part of a big family of the type 2 collagenopathies, and it's actually, in terms of phenotype, residing at the mildest end of the spectrum, and I will show you that in the next slide. It's usually caused by a loss of function mutations in type 2 collagen gene. And so it really represents the haploinsufficiency for type 2 collagen, in contrast to the other type 2 collagenopathies. Clinical manifestations, well, first of all, it's important to emphasize that, in fact, individuals with Stickler syndrome, they have a normal stature. So you cannot really consider Stickler syndrome if you are facing a child with severe short stature. So patients with Stickler syndrome, they have normal stature, but they are relatively short if you compare them with their unaffected SIBs or parents. They have early onset degenerative joint disease, starting already in childhood with joint pain, and sometimes also making early joint replacement, hip replacement, or knee replacement necessary in the 30s or 40s. Cleft palate is quite common, as you can see. They have moderate to severe myopia. And importantly, there is a risk for spontaneous retinal detachments, which occurs about in 40 to 70% of the individuals. And when the ophthalmologist looks at the eye, when he looks at the vitreous, he can see what is defined as a type 1 membranous vitreous anomaly. And again, I will show you that in one of the next slides. They do have hearing loss, but the hearing loss in type 1 Stickler syndrome is rather mild. It's sensory neural, but it's rather mild. It's mostly involving the higher frequencies, and it's usually not so progressive. So here you see the family, the conditions or the family of type 2 collagen disorders, the type 2 collagenopathies. And so these are actually three, you can categorize them in three groups. You have the lethal phenotypes with achondrogenesis type 2 and hypochondrogenesis as the most common ones. Then in the middle, you have the conditions with short-term dwarfism, with spondyloepiphyseal dysplasia congenita as the most common form. And then at the third group, you have the normal stature phenotypes, and that involves Stickler syndrome and also check dysplasia metatarsal type, which is in the differential diagnosis, and that I will discuss briefly at the end of my presentation. Here you see some facial features of children with Stickler syndrome. And again, I'm still talking about the COL2A1 related form, the type 1 form. So I hope that you can appreciate the mid-face hypoplasia, the flattening of the face, the small chin is clearly visible here. And the micromephria, the small chin, tends to improve by aging. This is a girl that was followed up by Andrea Superti-Furga in Switzerland, and he shared the slides with me. And so here you can see how the outgrowth of the mandibula is actually improving when the child gets older. Well, 15 years ago, in 2010, we looked at our cohort of patients that we had received, and this was still when I was in Ghent. It's not so important, but we collected at that time, in a period of 10 years, about 278 patients with type 2 collagen disorders and with Stickler syndrome in particular. And so of this cohort, we could actually have information of the clinical phenotype in 188 individuals with Stickler syndrome. And in this cohort, we found this cohort actually included 100 probands with a COL2A1 pathogenic variant. And so when you look at these pathogenic variants, you end up with 77 different variants. And these variants include either deletion of the entire gene, nonsense variants, deletions, insertions, duplications, or mixtures, splice site alterations. So we found 22 splice site alterations. And in those that we could further investigate at the RNA level, we were not able to investigate each splice site alteration, but the ones that we did, we could actually show that these splice site alterations do not so much result in an in-frame deletion, but rather in a frame shift, and so causing a premature stop codon. There was also one synonymous variant creating an cryptic splice site. There were 2 arginine to cysteine substitutions, as you can see, and finally there were also glycine substitutions. Now, glycine substitutions, as you may know, usually result in the other groups of the type 2 collagenopathies, either the lethal group or the short-term dwarfism group. And so this is a bit of a surprise maybe, but on the other hand, when you look at the position of the glycine substitutions, at least three of the 5 are residing rather at the amino terminal end of the type 2 collagen protein, whereas the glycine substitutions that are residing more at the carboxy terminal end, and then I'm talking about carboxy terminal with respect to residue 300, seems to be more causing the severe phenotypes. But as you can see, like it's always in medicine, you always have exceptions. So it's just some general rules that I want to touch on here. There were no really hotspots. 13 variants were observed in more than one proband. And so 70 of the 77 variants were predicted to result in a loss of function. So therefore, we can really say that as a general rule, loss of function mutations in the type 2 collagen gene are causing Stickler syndrome. And therefore, Stickler syndrome could be considered as the haploinsufficiency phenotype in this family of type 2 collagen disorders. So let's now go to and switch to the next form, the type 2 Stickler syndrome, and sometimes it's a bit confusing, type 2 and type 1, so I will try to avoid these types and just talk about the genes. So we are now talking about COL11A1. It's the second most common form, about 20%. It usually have autosomal dominant inheritance, although there have been a few families reported with recessive inheritance, so with B-allelic mutations. When we look at the variants in COL11A1, what do we see there? Well, we do see splice site alterations resulting in an in-frame deletion, missense variants like glycine substitutions, and in terms of splice site alterations, intron 50 is a mutational hotspot. So the message here is, in contrast to COL2A1, is that we do see here not so much loss of function mutations, we do see rather mutations that may have a dominant negative effect. In fact, if you have a loss of function mutations, or if you have variants that cause haploinsufficiency, then you don't see Stickler syndrome as such, then you rather see as a result hearing loss, non-syndromic forms of hearing loss. What are the clinical manifestations? Can you really make a distinction between COL2A1 and COL11A1 when you look at Stickler syndrome? I believe you can. And I'm listing here the most important things. Well, first of all, cleft palate is more common, but of course that is not useful. If you see a case with cleft palate, you don't know. But I believe that the facial phenotype is different, and I will show you that in the next slide. Patients with COL11A1 mutations, they have more flattening of the face. And that is really something that you should remember. They have a lower risk for spontaneous retinal detachments in contrast to the other type. And then the Vitre's anomaly is different. We'll show you in the next slide. The sensory neural hearing loss is more severe than in type 2 collagen. And also the changes that you can see in radiographs may be more pronounced. Well, here you see several individuals with either a mutation in COL2A1 or a mutation in COL11A1. And what I really want you to see is look at mainly at the profile. And I hope you do see my cursor. For example, if you look at this profile, this is a very flat face. Also here, this is very flat. And so if you compare that to the other cases, the flattening, of course, is also present there, but it's less pronounced. And so the ones that are that have the red line around them are the COL2A1s, and the ones with the green are the COL11A1. So I hope you can agree with me that COL11A1 has a more flattening of the face. So if you see these cases in clinic, you can already suspect which gene will probably have a pathogenic variant based on the flattening of the face. When you do radiographs, usually what you see in COL2A1 cases is a bit less pronounced spondyloepiphyseal changes in comparison to COL11A1. For example, you see less flattening of the vertebral bodies. There is a bit small epiphysis, but if you look at the COL11A1 cases shown here, you see more flattening of the vertebral bodies, and also here you see a bit more metaphyseal widening, a bit of a halberd configuration in COL11A1. This is more seen in COL11A1 than is seen in COL2A1, at least in my experience. These are pictures that I got from my ophthalmologist Bart Leroy in Ghent. And so here you see the difference between type 1 and type 2. The vitreous anomaly. So the type 1 vitreous anomaly, as you can see here in the scheme, is actually caused by persistence of the vestigial vitreous gel in the retrolental space, which is bordered then by a folded membrane. So therefore the name membranous vitreous anomaly, whereas the type 2 is more characterized by strings, beads on a strings kind of feature. There are people, experts in Stickler syndrome, that do believe that type 1 is always seen in COL2A1 and type 2 is always seen in COL11A1. But this is not always the case. At least I have seen some patients with a proven mutation in COL11A1, which did not have the type 2, but rather the type 1 vitreous anomaly. So please remember this. The ophthalmologists are good, they are very good, but sometimes they cannot really predict the gene. So the geneticist is still necessary, which is good, of course. So I'm moving now to the third type, which is COL11A2 related. And this is rare. So now we are coming into the rarer forms of Stickler syndrome. It has, again, autosomal dominant inheritance. And the variants in COL11A2 are a bit similar to the ones that we have seen in COL11A1. So these are splice site alterations. These are missense variants like glycine substitutions. So not like we see in COL2A1 where you have nonsense and frame shift mutations. So it's the same as COL11A1 with a dominant negative effect, as I put here between parentheses. When you look at the clinical phenotype, what is the difference between COL2A1? Well, cleft palate is less common. Very important, no, and I repeat, no ocular manifestations. So this is the non-ocular form of Stickler syndrome, and I will explain you in a minute why this is so. And then sensory neural hearing loss is also more severe than in COL2A1. It's a bit comparable what you see in COL11A1. So why is this? Why are mutations in COL11A2 not causing an ocular phenotype? Well, this is explained on this figure. So you see here the cartilage matrix with the collagen and the vitreous humors. And so in both cartilage matrix and in the vitreous humors, you have type 2 and type 11 collagen fibers present. However, if you look at the composition of these type 2 collagens, you see no differences with respect to COL2A1. So COL2A1, the composition of COL2A1 in the cartilage and in the eye is the same. However, if you look at type 11 collagen, which is not a homotrimer, but is a heterotrimer composed of procollagen chains from 3 genes, there you see that COL11A2 is present in COL11 in the cartilage, but is not present in COL11 in the eye. There it is replaced, at least the protein is replaced by the protein which is encoded by COL5A2. So that explains the fact that mutations in this gene will not cause an ocular phenotype. Let's go back to the table that I showed you at the beginning. So we are now left with the genes that are coding type 9 collagen, which is an heterotrimer and is composed of 3 different chains, alpha 1, alpha 2, and alpha 3. And you see it's the minority. Interesting, it's a recessive inheritance, as you can see. This is the most important feature to remember. When we now look back at the phenotypic features, what do we see? Well, if we compare now the different forms, we see that cleft palate is most frequent in COL11A1 forms, and it's not been reported so far in type 9 collagen forms. Myopia, well, no big differences, but of course absent in COL11A2 forms. And of course also the retinal detachment is absent in the COL11A2 forms. Retinal detachment is the highest in the COL2A1 cases. So patients with a COL2A1 mutation have a high risk for having spontaneous retinal detachments in comparison to the other forms. Then the hearing impairment is mild in COL2A1, is moderate in COL11, I would say, and is rather moderate to severe in COL9 forms. And then the skeletal manifestations, either on radiographs or clinically, and clinically you have the early onset arthrosis, you have sometimes scoliosis, you have a bit of joint laxity. So you can see there the percentages of these different forms. I will not discuss all the different COL9 forms, type 4, type 5, type 6. I'm just putting figures from the first report from Guy van Kamp, who actually is a Belgian geneticist, who reported the first family in 2006 with recessive mutations, with a recessive mutation in COL9A1. And as you can see, the mutation is a nonsense variant. And so the key clinical features of that family were proportionate short stature, not really extreme short stature like in the short stature phenotypes that we have seen in type 2 collagen. Genu valga, joint pain, flat face, normal palate, moderate to severe sensory neural hearing loss, as you can see on the right side, moderate to high myopia, vitreous changes, and mild retinal anomalies and mild radiographic changes shown you in the middle, a bit of flattening of the femoral epiphysis shown by the arrows, and also flattening of the metacarpal epiphysis. Now let's go back to the cartoon because I want to have your attention for, my cursor is actually out of battery, so I apologize for that, but I will guide you through the figure. So you see on the type 2 collagen that you see the type 9 collagen, right? These red, shown in red. And there you see that type 9 excuse me, type 9 collagen is residing on the type 2 collagen fiber, but it's also connecting with other proteins in the extracellular matrix like COMP and methylamin-3. And this is interesting because that explains why mutations in type 9 collagen, but also in the other matrix proteins like COMP and methylamin-3 can cause not Stickler syndrome, but can cause another skeletal dysplasia, which is multiple epiphyseal dysplasia. And there it is, it has a dominant inheritance. And remember, mutations in COL9, when they are recessive, they cause Stickler. When they are dominant, they cause this condition, multiple epiphyseal dysplasia. But multiple epiphyseal dysplasia also shows locus heterogeneity. It's not always COL9. Also, other proteins can be responsible. And the reason for that is shown in the figure because all these proteins are in some way connected to each other. And here we see two boys with multiple epiphyseal dysplasia. They essentially have early onset arthrosis with joint pain already starting in early childhood, mainly in the joint pain in the lower limbs, hips and knees. They have normal height, and then they can either have genu valgum or genu varum. And then you can see on the radiograph that they have severe dysplasia of the proximal femoral epiphysis and of the knee epiphysis. Now, when we look back at the mutations in these genes and try to make some genotype-phenotype correlations, then what I want to show you with that slide is first, when you have B allelic, shown in red below, when you have B allelic loss of function variants in any of these collagen 9 genes, then you get Stickler, okay? If you have mutations that affect the COL3 domain, and this COL3 domain is actually that part of collagen 9 protein that interacts with these other proteins like methylamin-3 and COMP. Well, if you have mutations, heterozygous mutations or monoallelic mutations in that COL3 domain, then you get MED. And so the mutations that have been reported causing MED, they all reside in the COL3 domain. And as you can see from the other figures, is that many of these mutations are mutations that cause splice site alterations, resulting in exon skipping. There is one exception for COL9A3, where you can also have a glycine substitution, as you can see on the slide. So that is the genotype-phenotype correlation for the type 9 collagenopathies. Recessive Stickler, loss of function, dominant or heterozygous MED, all residing in the COL3 domain of the protein. So this table now also show you the situation for COL11A1 and COL11A2. So I've just discussed the situation for COL9A1, 2, and 3. So for COL11A1 and COL11A2, I've shown you that mutations in this gene can cause Stickler, and these mutations are, with the exception of rare forms of recessive Stickler due to COL11A1 mutation. All the other ones are by definition dominant and cause Stickler syndrome or either Marshall syndrome, which is an allelic disorder. But you see that, for example, fibrogondogenesis is also a condition that is a type 11 collagenopathy, but that is caused by B allelic mutations in either COL11A1 or COL11A2. And OSMED is another condition that is caused by recessive mutations, but then in COL11A2. So I do realize it's maybe a bit getting confusing, but I really want to show you that these genes are involved in different phenotypes. Here's an example of fibrogondogenesis, which is usually a lethal condition. You see from the radiographs the shortening of the long bones. with a bit of a Hilbert configuration. You see flattening of the vertebral bodies. And so this is a severe skeletal dysplasia, usually lethal, either caused by mutations in COL11A1 or COL11A2. But they also have a bit of features that you see in Stickler, like the flat face and the micrognathia. Here you see a boy that was reported by Thompson et al. In 2010 with 2 mutations in COL11A1, but did survive. So some cases with fibrogonogenesis do survive. And here you see a case of OSMED, and OSMED stands for otospondylomega-epiphyseal dysplasia, as you can see from the radiographs. And this is due to recessive mutations, to B allelic mutations in COL11A2. And these patients do have short stature, but also hearing loss, cleft palate, then this particular nose, as you can see from the clinical picture, narrow thorax and large joints, reflecting the big epiphyses that are visible on the radiographs. And here you see another case that I got from Lorenzo Botto, 2 mutations in COL11A2. So this is another case of OSMED. And then you see the metaphyseal widening of the long bones. And when you look at the spine, you see these coronal clefts in the spine, which is another feature of OSMED. So I come back to one of my first slides, because I promised you to discuss also another condition at the mild end of the spectrum of type 2 collagen, which is check dysplasia. And so check dysplasia metatarsal type has, together with Stickler syndrome, the feature of having normal stature, but problems with early onset osteoarthrosis. It's an interesting condition. It's actually first described by Dr. Marek, who is an orthopedic surgeon in Czechia, in Czech Republic, in 2004. And the interesting thing about this condition is that it is caused by a recurrent pathogenic variant in COL2A1. It's an arginine to cysteine substitution at residue 275. And all cases that have been reported with this condition, they all have the same mutation, which is quite exceptional for COL2A1 mutation. So this is the only example of a hotspot recurrent mutation causing the same phenotype. And so these patients do have normal stature. They do have progressive degenerative joint disease. And really the hallmark feature that is important and that allows you to make the diagnosis is to look at their feet, and sometimes also their hands can be involved, more commonly their feet. When you look at their feet, they have these short toes, typically third, fourth, and sometimes the fifth. That is really a feature of the condition. Of course, this can also be present in other conditions, like in brachydactyly type E, or in pseudo hypoparathyroidism. But here you do see it, and you should remember it if you have a patient with a normal stature and with complaints of degenerative joint disease. When you see this kind of feet, then you should ask your molecular geneticist to look at this particular mutation. And maybe this is a bit old-fashioned, because we don't look at genes, individual genes anymore. We look at exomes and panels. But if you want to impress your molecular geneticist, maybe there you have a chance. They have normal palate and eyes, by the way, and hearing loss can be present. And so the radiographic features are essentially that of a spondyloarthropathy. And sometimes they can also have flattening of the vertebral bodies, as you can see at the bottom of the slide, where I show you the thoracic vertebral bodies. You see that the thoracic vertebral bodies are a bit flattened. So finally, I would say, of course, it's also important to say a few words about management of Stickler syndrome. Of course, this is something that you really can deduce from the phenotypic features that I have been discussing. Stickler syndrome is a rare condition. It's a condition that affects multi-organs. So therefore, I would say, like in other rare disorders where you have multi-organ involvement, these kids should be followed in a multidisciplinary setting. So craniofacial clinic or a skeletal dysplasia clinic. And then if you have severe Pierre-Robin sequence with respiratory compromise in the neonatal period, then you should consider tracheostomy. Sometimes mandibular advancement is still necessary, even when you have the tendency to improve the mandibular outgrowth, but some patients still have small mandibles causing malocclusion. And in those cases, it may be wise to consider mandibular advancement. Of course, you have to do surgery for cleft palate. Certainly important for the type 1 and the type 2 Stickler syndrome cases where you have considerable risk for retinal detachments. You should educate those patients, educate them about the symptoms and the risks. You should tell them to avoid contact sports because that is really at risk for having spontaneous retinal detachments. We usually ask them to have an annual follow-up by the ophthalmologist. And there's also some literature there that tells us that prophylactic retinopexy is good to prevent, is really considerable to prevent spontaneous retinal detachments because laser therapy, when there is a little tear, is sometimes not so effective and sometimes result in recurrence. If there is high myopia and refractive errors, of course, they have to be corrected by glasses. Of course, you have the standard follow-up and treatment for hearing loss. Preventive measures for reducing the degenerative joint disease. For example, one of the things that you can tell them is to avoid obesity, to not exaggerate in mobility. So these kind of general statements and general recommendations you can give them. And then, of course, if it's necessary, there is orthopedic treatment. And of course, at last but not least, is the genetic counseling. So I'm done with my presentation here. If we still have some time left, I also have a case, 3 slides on a case that I want to show you. But maybe some other people have also cases that they want to show. So I have it here in case you want me to show it.
Perfect. And thank you so very, very much. That was a great presentation. So I'm going to stop here for just a minute. That was quite a tour de force. I'm going to go through our announcements because some folks were just a teeny bit late and want to be sure we get all our messages out. And then we'll move on to the case. So again, welcome everybody. Great to have you at the start of our 7th year. Please take good care of Melissa and be sure you sign in. We are required to do that as part of the TeleECHO, and this goes for everyone, so please. And then, of course, we continue to offer free CME as long as you fill out the red cap, so don't forget to do that as well. Next slide, please. So what's coming up? Next month, please watch out. We hope we'll see you all at ASBMR on the first Thursday in September. So we will be on the second Thursday, September 11th. And Sandy Sandhouse will be talking about updates on the pulmonary aspects of OI. The following month, Chris Kovacs will speak to us on maternal mineral and bone metabolism during pregnancy, lactation, and post-weaning. So we're all over the map with all the craziness and challenges of rare bone disease. Lots of good things to learn. Then the OI TeleECHO, which is on Wednesdays, will be taking a breather starting in December. So don't miss their final episodes. Kathy Raggio will be talking about cardiovascular health next Wednesday. And then my colleague, Natasha Shore, will be joining us on October 8th for clinical and genetic evaluation of non-accidental trauma versus OI. Next slide. Now, again, I do hope I'll see you at ASBMR. I'm happy to say that rare bone disease has become a mainstay. And once again, we'll be supporting a pre-meeting symposium, Rare Bone Disease from the Genome to the Lived Experience. And the Pediatric Bone and Mineral Working Group dinner will happen on Friday, Future Therapies in Children with Calcium Dyshomeostasis. Now, you can register for both of those with your ASBMR registration. But we want to also invite you to our own early and mid-career investigator reception, which will be on Friday before the working group from 5:30 to 7. A great chance to meet new people. You need to sign up for that one of two ways. So we have for you right now, get your phone out, the QR code, and Melissa graciously put in the chat a way to sign in there as well, which may be easier. So do run to the chat if you don't have your phone ready. We're eager to say hello to you. And then, not last but not least, we are pushing forward with our Washington, D.C. Metabolic and Rare Bone Disease Club. So we actually get to meet each other locally. And remember that while this is an in-person free event with dinner, we also do a online version. So we're thrilled to have you join us there if you'd like, no matter where you're sitting. And on September 11th, so that's a big day, September 11th, we're going to have rheumatology and nephrology complications in XLH. And then we'll define it a bit more, but on November 13th, we'll be focusing on achondroplasia. So lots and lots coming up.